Good to see you in 2023. Going to share the screen. So our next task in the Genius class 2023 is the Parkinson's disease follow-up. Parkinson's disease follow-up. Candidate instructions. In this particular case, you're an FY2 in a GP surgery. A 62-year-old man has come for a follow-up. Okay. 3 months ago, he was diagnosed with the Parkinson's disease and placed on methyl dopa. Your task is to talk to the patient and address the concerns. But this particular patient is here for follow-up. In terms of the patient information, nothing much. 3 months ago, he had tremors in the hands and difficulties initiating the movement. He was referred to the neurologist and diagnosed with Parkinson's disease. And today is for a follow-up. He has got a question. What is Parkinson's disease? He didn't understand fully when he was in hospital, when he was diagnosed. So you have to explain to him what's Parkinson's disease and is it curable? Why did he develop this particular condition? Approach to the task, grips as usual. Then you take the history of Parkinson's disease. So the grips, normal introduction. Then when you go and take the history, we're going to be asking about the Parkinson's disease. I understand that you've been diagnosed with the Parkinson's disease. Yes. Okay. Just a few questions about what you were told about your condition. Okay. So what is your understanding of Parkinson's disease generally? Okay. Do you know what it is? Okay. And when were you diagnosed? And what symptoms did you have? Okay. In the first place, did you have any symptoms like tremors in the hands, difficulty in walking, or maybe falls? And were you placed on any treatment? What treatment are you taking? And are you taking these medications regularly? This is our data gathering. Even if some of the information is written in the task, we still have to ask this information. Social life is crucial as part of our history. How are you coping at home? Who do you live with? Or who else is at home with you? Okay. Are you independent in terms of daily activities, walking about, eating and drinking? You know, has the Parkinson's affected your activities that maybe you're having shaking in your hands, making it difficult for you to hold the spoons, knives, or to eat, or any equipment that you might need? Do you have any carers looking for you, looking after you? Okay, so we need that social history. Then you have to ask specific about the symptoms of Parkinson's. You know, are you experiencing problems walking? Have you had any falls recently? Falling is common in Parkinson's disease. Any problems with holding equipment, as we say, like knives or forks? During the social history, we will ask these questions. Any pains anywhere in your body or in your joints? It's important to ask these questions. Then let's ask about driving. Do you drive? If they do drive, we will need to ask this patient to inform the DVLA. It's not that they have to stop driving, but it's important for them to inform the DVLA. Usually, the car and the motor, license, okay, may drive if self-control is maintained. They can drive if it's for a car or a motor, they can drive if controlling is maintained. Okay, good. Then we should complete the other history. That is the P3 maftuosa, the ICE. Remember, ideas, concerns, expectations, okay, and the effects of symptoms on the patient life is crucial, which we're going to ask you, and as we discussed during our social history. Then you have to examine this particular patient. This is for follow-up. We should be asking about their symptoms, about their medications, if they are compliant with them. Then we should be assessing them. Are they still having symptoms of Parkinson's disease? Now, how would we perform an examination of the Parkinson's disease? One, it is an inspection. First, where the patient is sitting, look around. The patient may be having a walking stick. You need to see if there's any equipment around there. In particular, as we said, you watch for mobility aid, walking stick, Zimmer frame. Then you come look onto the hands. Yeah, watch the hands of the patient, even when he's just sitting down. Okay, so I'm just going to bend this one. When you start sitting down, you may see the hands, they're shaking, yeah, which we call peel rolling movement. You're going to just see the hands are shaking. So just watch them down, which we call resting tremor, peel rolling tremors, yeah. They are usually resting tremors. The hands are just shaking like that. Good. Then look for the gait. In here, you need to ask the patient to walk. What do we watch for? For the shuffling gait. Shuffling gait, this is reduced stride. The stride, walking with the patient are reduced. Hesitancy, difficult initiating the movement or turning. So when you ask the patient to start walking, they will hesitate to start walking. So you should ideally ask the patient to walk to the end of the room and turn around. So you're going to see the hesitancy when turning and the hesitancy when starting. Okay. Then fascinating gait. They have a fascinating gait. The patient walks faster. Okay, faster and faster so as not to fall down. Small steps, but faster, faster, faster. That's to prevent fall because they have got a tendency to fall either forwards or to fall backwards. So to prevent themselves from falling forwards, they walk faster and faster, 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 faster. Small steps, but walking faster. That is a fascinating gait. Hesitant is difficult to initiate, to start walking or to stop and turn around. Shuffling is a small stride. Then the lack of arm swing. When the patient is walking, there's lack of swinging of the arms. Okay, they're just walking, a little bit more quicker, but there's no swinging of the arm. It is an early sign. It is due to increased tone. Unsteadiness. They tend to have tendency to fall, usually forward or backwards, which is what we said. That's why they have got a fascinating gait, walking quicker to shift so that they don't fall forward. Okay, Not. So you should ask the patient to walk to the end of the room and turn around. You need to follow the patient as you observe because they may fall down, to protect them somehow. So you stand on the sides, be with them so they do not fall down. So that is examination of the gait. Then look at the posture. Observe the patient while it's walking. They tend to have a stooping posture, stooping posture while they're walking in there. So that's what we're going to be looking for in terms of the posture. Now we work down the body. From the face, we work all the way down. Face, you look for mask face. Okay, there's a decreased blinking. Okay, everything is decreased facial expressions. Okay, so just gonna remove that. Just 1 second. So this part is not supposed to be there. Okay, decreased blinking, for example. Speech. So let's make it bigger. Good. Speech. Okay, it's a softy, fainty voice. Okay, you may ask the patient to describe the room. Can you just describe this room? How does it look like? Just any way you want to describe it. Then you're going to watch for their speech. It is a softy, fainty voice. Okay. And then, of course, you're going to find it is a fainty, which means monotonous speech. Yeah, you're going to hear the monotonous speech. Would you just describe this room for me? How would you describe the room we are in? Then you watch the way they speak. It's going to be monotonous speech. So that is a speech. Then you come to the upper arms. Here you do an examination, tone, power, reflex. Okay, and then you have to assess it for bradykinesia. Now, here, assessing for bradykinesia is simply to assess for speed. Open and close the thumb and index finger as fast as possible. Just you can do this as fast as you can. Let's say, for example, as fast as you can try to do this, they will be slow to doing it. Okay, play an imaginary piano. So let's assume you're playing a piano and play it as fast as you can. Play the piano as fast as you can. You're going to see the slowness. So these two, they can demonstrate the bradykinesia. Okay, any one of them you can try to ask the patient to do, can demonstrate the bradykinesia. So just changing up there to make sure it is clear for yourself. Good. So that is upper limb. Now, when you come to the lower limb, again, you have to do the tone, the power, the reflexes. Remember, when examining the patient has to lie on the couch, and you're going to do it together. First of all, the whole inspection together, and then you're going to do the tone together, then power together, then the reflexes together. So check the tone, upper limb and lower limb. Check the power, lower limb and upper limb. Reflexes, upper limb and lower limb. Okay, and then, of course, you check for bradykinesia of the lower limb as well. Just tap on the bed with your heel. So patient is hitting with the heel, just hitting the bed. See how quickly the patient can do it. And you're looking for what? Slowness, tapping on the bed with your heel. Okay, good. So it's as simple as that. Patient is lying on the couch, just tap on your bed with your heel. Then you're going to see patient tapping on the bed, and is being slow. Good. So that is the examination. Now, this particular patient already has got a diagnosis. Okay, this particular patient already has got a diagnosis. So we don't need to give a diagnosis. We just have to do explanation of things. In particular, explain that Parkinson's disease is a progressive neurological condition. This means it causes problems in the brain and it gets worse over time. It is a progressive neurological. It does get worse over time and it's a neurological disease. Neurological means it causing problems in the brain and causing problems in the brain. And progressive means it getting worse with time. The person with the Parkinson's disease do not have enough chemicals, okay, enough of the chemical dopamine in the brain, because the cells in the brain that produce dopamine have died. So there is a damage, or the cells that produce dopamine, they die, and therefore the level of this chemical dopamine in the brain is reduced. And this causes symptoms such as what? Slowness, being slow in doing things, rigidity in your joints or in the muscles, and tremors in your hands. The cause of Parkinson's disease is not known. In this particular case, an idiopathic Parkinson's disease, meaning the cause is not known. The treatment is what you're already being treated for. Okay, the medication methyl-dopa. So patient has to continue taking the treatment of methyl-dopa and take the medications regularly. The task told us that the next follow-up in this patient is going to be in 3 months. So we're going to explain to the patient that your next follow-up is in 3 months because the task is said so. If it didn't tell you the next follow-up, then we cannot make up our own follow-up. Or for the leaflets about Parkinson's disease, okay? And then you need to refer this patient to the multidisciplinary team. But ask, have you been referred to the multidisciplinary team? So patient might benefit from input from different specialists. Thank you.